Hello, everyone. My name is Chanel Blackwood, and I am the marketing manager at AHIA. Welcome and thank you for registering for today's webinar, Efficiency Measures of Health Systems and Universal Health Coverage in Ghana. Before we begin the webinar today, I just wanted to run through a couple of housekeeping items. If you experience any technical difficulties today, please write them in the chat box at the bottom of your screen, and I will happily assist. Everyone on the line has been muted to eliminate background noise. If you have any questions during our webinar, please utilize the chat box or use the raise your hand function. We will be holding all questions until the end of the session when we'll open for a facilitated Q&A. If you have any other questions, please send them through the chat box. I will now pass it over to Pavrika Paul. Pavrika, over to you.
Thank you, Chanel. Good afternoon, good morning, good evening, wherever we are. It's indeed a pleasure and welcome to all of us for the first webinar of this year, 2022. Today, our faculty is Dr. Emmanuel Odame, and he will give us the insights about the progress of universal health coverage in Ghana with a unique approach of measuring the health system's efficiency from the lens of scorecard. Thank you very much again. And as all of us know that Health Systems Efficiency Examination Group of AHIA is a conduit between the researchers and the members of AHIA with the different national governments to develop evidence-informed health systems. We welcome your active participations. Please feel free to raise your questions in the chat box. And whenever you write the questions, please mark everyone so that we do not miss your questions. At the same time, you are also welcome to raise your hands. You can go to the reaction icon at the bottom of your screen and choose raise hands. Whenever you choose raise hands, then Chanel will make you unmute and Dr. Odame will get the privilege to interact with you directly. Thank you very much again. Welcome to all of you. Now I request Dr. Odame to introduce himself about his work and continue the session. Dr. Odame, please.
Yeah, so thank you so much, Prof. Pavitra, for this opportunity. I'm Dr. Emmanuel Odame. I'm the Director for Policy Planning, Monitoring and Evaluation, Ministry of Health, and also the lead for universal health coverage in Ghana, and also the technical lead for the Sustainable Development Goals for health. In fact, I'm the technical lead for the development of an universal health coverage roadmap and oversee the work on the scorecard assessment at the ministry. So basically that's about me. And I want to take the opportunity to thank AHIA for this opportunity to make this presentation. So I'll go straight to the presentation with your permission. Please, can you see my slides?
Yes, we can see them.
Please, can you see my slides?
Yes, I can see your slides.
Yeah, so the topic, as we mentioned, is efficiency measures of health systems and UHC in Ghana. Please, just a second.
Looks good, perfect. Oop.
Okay, please, can you see it now?
Yes, we can see it. It looks good.
Okay, so by way of presentation, I'll do the introduction to the healthcare landscape, our universal health coverage roadmap, the national health insurance progress that we have made, introduction to our health status scorecard, and then we'll round it up then. So by way of our landscape, universal health coverage is included in our sustainable development goal target 3.8, and there are two clear indicators, one on service coverage and the other on financial protection. And we in Ghana, strengthening health system is the most efficient and sustainable approach to achieving universal health coverage in Ghana. As is often said, never waste a crisis. And we've learned some lessons from our COVID pandemic that came into the country and globally. That something that started as a health issue became an economic issue. In 2021, our GDP forecast was 5.9. We had to recalibrate it to 0.5 because of the COVID pandemic. So clear economic issue, it ended up as a social issue, became a security issue. So the clear lesson we've learned from COVID is that we always need to think system. Also within COVID, we saw huge gains in IT infrastructure, building our IT systems, Zoom meetings, and all other things. Clearly, it's also about digital capabilities. And we've seen that there are two clear revolutions that confront us, the digital and the genomic revolution. Ghana has been a keen advocate of SDG and has also been a key advocate of the Global Action Plan for Healthy Lives and Wellbeing. After it was mooted by His Excellency the President of Ghana, His Excellency Nana Addo Dankwa Akufo-Addo, with the Prime Minister of Norway, and Solberg, and the Chancellor of Germany then, Angela Merkel. And Ghana got this Global Action Plan done with 4 key principles: engage, accelerate, align, and account. We also played a leading role in a group of friends of UHC, and are also part and parcel of the UHC 2030 Steering Committee, of which I am a member. So by way of what has happened in the global health perspective, we had the MDGs, we had goal 4, 5, 6 all around health. Then we have SDGs, which is a clear goal, ensure healthy lives for all at all ages. And then UHC being a key thrust of how we go around it. So Ghana has gone ahead to develop what we call the Universal Health Coverage Roadmap and also our National Health Policy. We have looked carefully at the definition of universal health coverage. And in contrast to a global definition, we spent close to half a year to agree amongst ourselves what we define as universal health coverage to a Ghanaian. And we've come up with this definition that to a Ghanaian, universal health coverage is all people in Ghana should have timely access to high quality health services, irrespective of the ability to pay at the point of use. So you can see there are some clear differences between the Ghanaian definition and the global definition. We've qualified access with timeliness because we define the services we want to cover, i.e. emergency services, preventive, promotive, curative, rehabilitative, palliative, and mental health. And then we realize that time is of the essence if we are to achieve any of this. So it just cannot be access, but it should be timely access, especially in the context of emergency care, both public health and clinical emergencies. And COVID has taught us clearly the lesson that time is always of the essence, even emergencies. We've also qualified quality with high quality, but we are clear with that we've got to the point where it's just beyond infrastructure of health services, or just the HR, and it's also about getting accreditation seals, national accreditation seals, local accreditation seals, quality of our HR, So it needs to be high quality, and we put emphasis on that. Then also, we are saying that people should not be denied healthcare service because they cannot pay at the point of use. So based on all this, we want to strengthen our national health insurance scheme, which is a global leader across the African region, and still doing more until to strengthen it. With major reforms around provider payments and other things that we are doing. So this is how come we came up with the Ghanaian definition based on our local circumstances and what suits our context in the best possible way. So if our universal health coverage roadmap, the goal is to ensure increased access to quality essential healthcare and public health services. And I've mentioned the services: preventive services, promotive services, curative, rehabilitative, palliative, emergency care, and mental health. And the objectives are threefold. One, increase access to better managed quality primary health care services. Universal access to interventions aimed at reducing maternal, newborn, adolescent deaths and disabilities. And universal access to clinical and public health emergencies. So we did a rough schema and with subject matter experts, and we use NHIS active coverage as a proxy for curative services, since we cover about 95% of the disease conditions. And clearly, we just about 50% roughly. Preventive services, when we start to the experts, like 40%. Promotive, very low, about 20. Rehabilitative and palliative were huge gaps. In fact, we could not even quantify because the infrastructure is not even well developed in the first place. The emergency care, mental health. So we have quite a long way to go based on this, working with the subject matter experts if we are to achieve universal health coverage, especially looking at the palliative, rehabilitative services and even mental health. Then we've also looked at our NHIS group over time, the membership group. You can see we made some major gains from between 2005 to 2009. In 2009 to 2010, there was a dip, and then the growth has been a bit more slowly going now, and now picking up once again. So we will look at the total amount of members is a rough estimate because that one, some may not have renewed. So we just focus on the active members, but that's the key variable. The active members are those who have renewed and still active on the system. The total amount is those who may have rested over time, but the active members that shows those who are still on. And then clearly you could see that a lot of our people are at the age of 18 and we have a huge informal group also as part of it. Now to the introduction of what we are working on now in terms of assessment of our community perception, the health sector scorecard. This amendment 2, which is create a color-coded dashboard showing the performance of selected health indicators. It helps improve accountability by tracking the progress of recommended actions to address performance gaps highlighted. So it's not just about seeing the gaps, but it's also about how we track the progress of all these gaps. So this is how it goes. So we'll pick a few in Ghana setting that shows that for malaria, if you pick malaria, the mass treatment coverage for neglected tropical disease is an area with not that much. Estimated of total population living with HIV who have access to antiretroviral therapy, it's yellow code, so it means we still have some progress to make. Percentage of population fully vaccinated against COVID is a huge gap, which is still red, so it tells you that we need to do more in that area. So really, COVID has put a huge strain on our health systems, and health systems are required to maintain some of this routine health services, even as an additional burden, in order to prevent widespread morbidity and mortality. It is of vital importance. In Ghana's context, we realize that in order to plan for universal health coverage, you need to work more for ancestral treated net. You also do need to avoid fiscal accordance with recent guidance and community. What we've also done is a seasonal malaria, what we call seasonal malaria chemo prevention. And Ghana is really congratulated for completing the seasonal malaria chemo prevention in a long-lasting insecticide net campaign. There are some challenges because we are still seeing a lot of malaria deaths, but it's essential to see to a continuity of our malaria and RMNC services, that's our reproductive maternal newborn child and adolescent services. We've also secured some resources through the Global Fund for our essential anti-malaria commodities to sustain coverage in 2021. And I've also developed sufficient numbers of our long-lasting insecticide nets. And Ghana has also scaled up coverage, and we are looking at 100% coverage of those most at risk. In line with the legacy agenda of the ALMA chair, African Alliance for Malaria Alliance, His Excellency President Uhuru Kenyatta, Ghana has simply tracked and enhanced the tracking and accountability mechanisms with the development of this malaria elimination scorecard. We've had some few challenges with insecticide resistance as we've done it across the country. So though Africa did not achieve the African Union 2020 target of reducing malaria incidents, at least we should achieve one of the targets, and Ghana is amongst about 6 other countries that have achieved one of the targets. Now, in the area of RMN-CH and neglected tropical disease, the country has also achieved high coverage of our tracer RMN-CH interventions, including exclusive breastfeeding and also postnatal care. We've also increased coverage of our skilled birth attendants and also improved upon our maternal newborn and child health scorecard. And we've also gone ahead to publish our RMN-CH scorecards on the ALMA scorecard hub. In the area of neglected tropical disease, we've also made progress and come up with a composite index that's calculated from the preventive chemotherapy coverage with lymphatic filariasis, onco, schisto, and soil transmitted helminths and trachoma. In 2020, the preventive chemotherapy coverage was 100% for these conditions that I've mentioned. So these were some of the recommended actions we put on the table. So to continue of our RDTs and a lot of our promotional activities, working with civil society organizations, and also with the Global Fund to strengthen our long-lasting insecticide nets and seasonal malaria chemo prevention campaigns. So this is all based on the data. Then now we act the whys, and then we've looked at the approaches that we should do to improve upon the data. In the same area, in the area of neglected tropical disease, we're looking at a negative impact of COVID-19 on the coverage, ensure that our neglected tropical disease interventions, including vector control and mobility. So we've had 3 rounds of our mass drug administration for most of the neglected tropical disease, and we started seeing some improvement in targeted districts based on the data. And we also want to address the falling coverage of vitamin A. So I want to say thank you once again, but I want to leave it on a slide again. So I'm going to stop share and put it on a slide that's a comparative of the countries. In just a second. All right. Okay, it's okay. I think we can go to the questions time now. Over.
Well, thank you, Dr. Odame. We have not yet received any questions from any one of the participants, but still we are having a lot of time. We encourage to raise your hand so that you can be unmuted for direct interactions.
Bruce, do you want to go ahead with your question?
Thank you. Yes, that would be good. Could you just tell us a little bit? Thank you very much for the presentation, by the way. It's really interesting and made me think about a few different things. Could you tell us really a little bit more about the next steps and how this work can be used in policy, service delivery, different aspects in that respect, please? That would be really interesting to hear a bit more about.
Dr. Odame?
Okay, thank you. I thought we were going to take more than a question before I come in, but with your permission, I'll go ahead. So what we've done with the scorecard system, like I said, it's an accountability tool. So based on the results, actually it's written straight to His Excellency the President. Then he writes back to the sector, because after we've done, we get it through to the system. Comes back, then we at the policy planning take it to the implementing agencies, and then ask ourselves, why are we having these challenges? We ask ourselves why 5 times, and then do what we call the bottleneck analysis. And then after we've uncovered it, that then goes into policy thinking, implementation planning, and then we change our approaches. So we have focal points for scorecard in our implementing agencies, the Ghana Health Service, and also have the focal point at the Ministry of Health to ensure that these things are carried out. So that is how we work on it. Over.
So you have kind of a process in place for taking this forward, or have you any examples of how this would be used in practice?
Yes, so let me go back to the slide. Okay. So if you pick this one and then ensure that malaria services, including case management and vector control, are sustained, you see the comment that came that do we have adequate stocks of our ACTs, anti-malaria chemotherapy drugs, our rapid diagnosis tests, and then whether we complete the IRS campaign. So with this one, practically we engaged the National Malaria Control Program, and then they took these steps, and then where they were lacking, they go back to the center for us to see how we move it forward. So practically we work with all these groups. And the civil society organizations also help in putting pressure on the system and ensuring that these recommended actions are taken. Over.
Okay, thank you. Very interesting.
Well, we are having a lot of time. So any one of you, please feel free to have an interaction with Dr. Odame on this interesting topic, scorecard approach to understand the performance of the health systems on certain dimensions.
Yeah, I think I've seen a question in the chat box about what caused the dip in membership. Can I please answer?
Yes, of course. Please go ahead.
Yeah, so what we realized was that the renewal was the issue. So if you look at the total number of members, it was a bit more, but the active members were a few. So that was a bit of the challenge we foresaw. So now what we've done, that we are even aligned for mobile renewals. And since then, that was about last year or so, since I've started picking up again. Over.
Chanel, can you unmute Arhin?
Can you hear me, please?
Yep. Quadwo, if you want to go ahead with your question, you're unmuted.
Thank you. Thank you, Dr. Odame, for your presentation. As you said, UHC has 2 main focus, that is financial protection and service coverage. Now you talk more about the service coverage in terms of malaria reduction, HIV, tropical diseases. But on the financial protection side, you only show us one slide looking at the trends in the insurance coverage, that is the health insurance coverage. Can you help us? Because we know in Ghana, there are many people who are not able to access health services because they cannot pay, they cannot make direct payment when they go. Can you, throw more light on the financial protection side of the UHC?
Okay, thank you so much, Mr. Dr. Kojoahen. Yeah, you are right. I mean, the essence, I focus a bit more on the service coverage in line with the scorecard. The financial risk protection is an area that Ghana has also made some progress, I would say. Our health insurance coverage, like you saw from the membership, is close to about 50%. We have a benefit package it's about 95%. Currently, we are even trying to bring on board family planning and also some of the cancers, especially for children cancers. Having said this, I also want you to know that it's also been a bit difficult with the fiscal crisis, COVID and all that, in improving upon our health systems. So we are currently reviewing our health financing strategy to have a clear strategy in achieving UHC in the midst of all this that we have said, a financing strategy that will guide us in orchestrating our efforts. And that's why we back down even the mobile renewals for NHIS membership, so that people can more readily have access to NHIS services. We are trying to also introduce a mental health levy to improve upon our mental health services, since we pay mental health directly from government sources. So these are some of the few things we've done. And we are also doing resource mapping, even to identify all the resource sources we have in the country in knowing how we move forward. Over.
Hello, any one of you? Because we are having a lot of time, so Dr. Odam is also available. Please make this session much more interactive. Any more questions to ask? We can conclude this session, and all the session slides will be available on AHIA web portal.
We actually have one more question. Quadwo, would you like to go ahead?
Dr. Adame, thank you for your reaction to my first question. My second one is that World Health Organization report indicate that about 80% of diseases that are treated at the secondary level can be treated at the primary health service level. So if we want to achieve UHC, then we need to pay more attention to primary healthcare services. What is Ghana doing to expand its primary healthcare services so that majority of our people who are in the rural areas, hard to reach areas, can also be served? Thank you.
So thank you so much, Mr. Dr. Kojoahen. So like I said in my presentation, we've developed the universal health coverage roadmap, which has 3 objectives, which are 3-pronged, to create a strong primary healthcare service, essential primary healthcare services, and then to strengthen our reproductive, maternal, newborn, child and adolescent health, and also strengthen public and clinical emergencies. So our first objective actually is on strengthening our primary healthcare services. We've also realized that it cannot be business as usual. The issue primary healthcare has seen in the world is that it's made to seem as if poor care for poor people. We are trying to redesign it to make it smart care for everyone. So we've introduced what we call the network of practice, where we are now going to link the centers at a different level, the community and the sub-districts, to have some leadership around it and provide all the services I mentioned: preventive, curative, rehabilitative, mental health, emergency care. So anyone who goes into the system has access to all these services in a defined package. We've also developed our essential health services package, which has clearly outlined all these things, which is going to feed into the benefit package of the National Health Insurance Scheme. So this is how we've approached it. And we know that with this new recalibration, we should make some progress in strengthening our primary health care services. In order to address the question that you asked, ensure that 80% of the services will rather happen at the primary health care level and not at secondary care level, so as to free up the secondary care to manage the more complicated cases. Over.
Jackie, you can go ahead.
Hello, thank you. Thank you very much. And thank you for a very interesting presentation, Dr. Adami. I had a question about whether your indicators include anything on workforce. I'm sorry if your presentation included that and I missed it, but I just wondered whether, to what extent you look at the use of different types of healthcare workforce in the context of closing some of the gaps that you identified.
Yeah, so we looked at the health workforce, but I've not presented it here. I've not presented it here, but it's an area we looked at as part of the work we did. And we've seen gaps in the health workforce, and that's also been addressed. We formed an HR team to even look at the brain drain and also how to even have incentives to attract people into our deprived areas, because that's one of the challenges we've also seen, and getting people attracted to our deprived areas.
Yes.
So we're also working in a different strand of work, which I didn't present here, but it's something we are working on. Over.
Okay. Thank you. Thank you very much for that. I'll switch myself off again now.
Hi, I'm Chloe here from the University of Sheffield. Thank you. That was a really interesting talk. I just had one question about the NHIS membership, and I was wondering whether you see any difference in distribution across regions, with some areas being more enrolled than others, or whether it's quite uniform across all regions. Thank you.
Yeah, please, your name again and your institution. I didn't hear you well.
My name is Chloe Tuck from the University of Sheffield.
Okay, good. So what we've seen is the NHIS enrollment is not uniform across the regions. In some regions, it's a bit more, especially the rural points, but even a bit low in some of the urban points. So it's something we have been asking ourselves questions: what influences the enrollment? And we've realized that people enroll once, but they don't renew. So that's why we introduced a mobile renewal. Now that increasingly more people hold mobile phones. So, but with that, we are seeing *422#. People are starting to renew a bit more. But it's something we want to research into and see what causes the variation in membership rate across regions. For you may know, people are also not comfortable with the benefit package. And we also instituted our national quality strategy to work on quality management systems across the country, because we also want to address that part of the conversation. Over.
Thank you. That's really interesting. Thank you for your reply.
Well, we don't have any more questions, and still we do have some time. And if we do not have any more observations or issues to discuss with Dr. Odame, we conclude today's session, the first session of March of 2022. We'll be having a couple of more webinars during this year as part of FSIG AHIA activities. You are always welcome to give your feedback as well as write to me for any of the suggestions to improve the activities of FSIG, which acts as a conduit between the researchers and the members of AHIA with the different national governments to develop evidence-informed health systems. Thank you very much for all of your participation. Thank you, Dr. Odama, for giving us wonderful insights for using a scorecard approach in understanding the efficiency of health systems. Thank you again to all of us. Bye.
Thank you all too, and thank you for the opportunity. Bye.